Okay, so sorry about that. Can everyone, okay, if you can hear us okay, can you drop a message in the chat? You can hear us? Okay, perfect. Awesome. All right, so I think you could probably just hang up the audio on your phone if you needed to. I don't know. Or just turn it all the way down. Should we go over the bios again, or we could just post those after?
Tell them we'll post the bios.
Okay. We're going to go ahead and just jump right into the questions. I'm not going to read the bios again. We apologize for that. And we'll post the bios of all the presenters after the meeting so we don't waste any more time. So we really only went through a couple questions, so we're going to start over. So question number 1 is for Bridget. Are you seeing sweeping changes in the telehealth and virtual visit coverage? Is it including mental health care as well?
Yes. So there are sweeping changes happening in coverage for virtual care of all kinds, not just mental health and primary care. It's kind of across the board. And historically, CMS has been very restrictive in how they allow for telemedicine to take place, being very specific that they're trying to create access in rural communities where access is often limited. And so now those guidelines, because of COVID, have really been kind of erased. And so patients can now be anywhere. So again, in the past, patients had to be in what was considered an approved originating site, which the breakdown of that is in a hospital or a clinic that was in a rural location. And they're very specific on address even. And for us, excluding places like Marshfield and Rogersville, those places were not considered rural enough, I guess, to meet the originating site approval. But now that it's all changed, patients can be in their home, they can be at their place of employment, they can be in the car on the side of the road and receive care wherever they need. And so that's probably the biggest change that we've seen. So it's been exciting to watch those changes happen.
Absolutely. All right, thank you so much. The second question is for Jess. Is there any speculation as to how most plans will approach a potential COVID-19 vaccine in regards to cost sharing? One would assume it would be costly, at least early on.
Sure. Yeah, if and when a vaccine is released, I think we would all anticipate that being covered with no cost share to the member. Hospital systems, I think, would encourage that as well. The cost of delivering care to treat, if it's not available, would be a multiple of that factor. So, yeah, I would anticipate seeing that being covered under the cost share agreements that are currently in place for COVID treatments. The question is when and how that vaccine is released.
Awesome. Thank you so much. Okay, so the next question is for Erica. Can we expect any major cost increases, or is there any way to be prepared for what could happen?
Yes, so the COVID impact, I'll discuss that portion first because that's the main question I get from a lot of my clients is how is COVID going to impact our insurance rates? And unfortunately, right now, it's an unknown because most plan utilization is down right now because you have a 2-month period in which, individuals cannot seek services for elective procedures. And then you also have the majority of the population where it's they're still a little hesitant to get out and seek services. So from what we're seeing, especially on those groups that receive claims data, the utilization is very low at this point. We're also in a unique area in Southwest Missouri where, although COVID has most certainly impacted our community, we have not been a hot spot here in Springfield, Missouri, like, New York and Washington, D.C., and some Atlanta, Chicago, some of the bigger areas. And so while it's great that we have not been a hot spot, majority of our carriers write business on a national level. So at some point, that is going to come back around to our area at some point. My recommendation for any employer is to always at least budget a 10% increase. you may or may not get it, but 10 to 12 is always that safe mark. I've certainly seen renewals well below that, but I've also seen renewals that are much higher than that. So, and my only other recommendation is, depending on the size group that you're in, look at your claims data if you receive it, and that will give you an idea how you're running, how your plan's performing, and whether or not to anticipate a significant increase.
Awesome. That's great advice. Thank you. Okay, so the next question is for Jeff. So with the rise in mental health concerns due to the pandemic, will there be changes to coverage of mental health services? And then I guess as a follow-up to that, what benefits should employers make sure are covered under their insurance plans to help employees deal with mental health crisis during this time?
Sure. So kind of two parts to that question.
Yeah.
First of all, I think as far as access, I think that's already starting to change through telehealth, quite honestly, not only from the medical side, but from those specialists and providers like psychiatrists, psychologists. Having access has really changed already. So yes, I would assume that would continue to expand through this and even beyond, as providers and members are seeing the value of that. As far as what should be covered in addition to that, a lot of employers, like I said, the Mental Health Parity Act has already included a lot of the access and coverage for those services. It's whether or not the members are actually seeking those services proactively versus waiting too late. In the large group world, even though it wasn't required post-ACA, it's always kind of been embedded. Where I see a shift is employers starting to have our about EAP embedded service. So adding value through EAP services in addition to the medical coverage, maybe more proactive approach through telehealth services. And those generally expand beyond the actual medical coverage and focus on the holistic approach of mental health in general, financial stresses, family stresses, the stresses of changing and adapting to COVID is a big hot button issue. So EAP services, in addition to the medical coverage that's in your health plan, I think are going to start expanding even more so than they already have. And people are going to start seeing value in those. But for the longest time, they're very difficult to kind of calculate an ROI on EAP services, because it's hopefully preventing claims, right? Preventing those larger issues, but there's not a really good way to measure that. And then, of course, with HIPAA laws, you don't get a lot of claims reporting on EAP. They aggregated data typically. So it's kind of a faith approach to it of, hey, I'm providing the service to my members in hopes that it's doing some good. And generally the costs are pretty low as well. So yes, I definitely see those expanding in the years to come.
Awesome, thank you. And yeah, just as a follow-up to that too, you know, even if you don't have an EAP program, I know many of us as HR professionals sometimes have to wear many hats, and counselor is sometimes one of them. But, you know, just as the HR person, you could always, you know, give those national resources and state and local resources to your employees, whether it's just in a one-page guide or just an email that you send out, you know, even if it's related to COVID. So just keep that in mind as you wear those hats in HR. Okay, so number 5, this one's for Bridget. So what changes do you see upcoming for telehealth services in the area?
Yeah, I really think, you know, the sky's the limit. We've had virtual visits on demand services for quite some time. And then we've also rolled out primary and specialty care visits for patients to do at home on a more scheduled basis. But we've expanded very much in our hospitals as well. So I talked about where patients can be anywhere. They can also be inside our hospital where the physician's actually in the building, but we're using telehealth to cut down on PPE usage. We're using it to reduce exposure for both the patients and our staff so we can keep taking care of more patients. There's definitely more coming down the road in the mental health space. And then one other one, you know, that I'll highlight is what we're calling telesane, which is your sexual assault nurse examiners, if you guys have heard that terminology before. When victims come to our hospital and need that type of care and those examinations done, forensic medicine is actually one of the largest growing areas of medicine. And so, but not all hospitals have sexual assault nurse examiners 24/7 around the clock in all the areas. And so using telehealth to have experts here guide those nurses in the other hospitals, provide training programs for them, because it is very, very specific. So there's lots that we're doing. One other highlight is around maternal fetal medicine. I'll let you guys. No, you're fine. I'm sure it's annoying for our viewers. So, you know, what we see in a lot of rural spaces is women with high-risk pregnancies that maybe can't come into a Springfield, a Kansas City, a St. Louis area to receive that higher level of care for their babies, and so we can still treat them in their local hospitals and see those patients, and then have them scheduled to deliver in an area that's truly going to be a high risk, rather than delivering somewhere where they don't have a NICU available to them, and now you're transporting a high risk, you know, child, a baby, infant, all the way to somewhere else. So there's just a lot of growing areas, and there will be a lot of things that blow all of our minds as we move along.
Absolutely, yeah. Okay, so the next question is for Erica. What is the best way to answer and communicate widespread COVID-19 employee benefit related answers and announcements to our entire organization?
Yes. So there are many ways in which you can communicate the information to your organization. Of course, typically in this day and age, electronically is going to be the best way to communicate. So if you have email for all your staff, email, company intranet. I have a lot of manufacturers, so when you have, you know, guys and girls out in a plant, they don't have access to that computer or that work email account. And so a lot of time clock systems are very current, in which when they clock in for work, they're a message, you know, you can give them a message about COVID related or any information that you want to communicate. But then there's never anything wrong with being old school, you know, paper messages, posters in your break room. And then, of course, a lot of my clients also have weekly meetings, although they're not in person right now, you know, just weekly staff meetings or weekly sales meetings that they have with their employees, and you can certainly communicate it in person as well. So, you know, technology is probably going to be the quickest. So if you can do, like I said, email, company intranet, or the time card system, but there's never anything wrong with paper or in person.
Absolutely, yeah, thank you. And, you know, some of our payroll systems and time clocks, they even have apps nowadays, and so most people have a smartphone, I feel like, even in construction or even different industries. So, you know, sending out like a push notification on an app or something like that could be an option as well. So, awesome, thank you. Okay, so the next question is for Jeff. So how will healthcare in 2021 be different than other years after a major disease outbreak? So, for example, maybe the years following the major flu outbreaks, Ebola, H1N1, et cetera.
Sure. So, I mean, I think we all know that the biggest difference with COVID-19 is the economic impact that it's had. I mean, we've had outbreaks before that have a large effect on the healthcare system, but this is expanding beyond the healthcare industry and even our roles. This is affecting employers, which then affects budgets, which then affects decisions for the benefit plan. So it's got a kind of a ripple effect that's reaching far greater than any of the other outbreaks we've had in the past. The other fact that it's an election year changes how that approach is handled. So depending on what happens through the election cycle, probably changes the course of action from there. As far as an overarching view, our lifestyles have changed considerably. I think part of my client base is saying, why are our claims so low right now, but we're still expecting, right, a potential increase here? Well, as Erica mentioned before, it's because people have shifted their focus and saying, I'm only going to get that procedure, or maybe I can't get that procedure done right now. But as a culture in general, if we look back at our grandparents and our great-grandparents' generation, knee surgeries, hip surgeries, shoulder surgeries weren't being done well into your 70s and 80s like they are currently. Not saying that that's a bad thing. The advances in medicine are great, but they come at a cost, right? If we're performing more procedures well into our later years and we're living longer, those costs stack up, and that those dollars have to come from somewhere. So I think people's kind of eyes are being opened a little bit to that the cost structure is not coming necessarily always from the critical care issues. It's coming from elective procedures as well throughout the year, where you're going to see, I think, claims issues is in the following years where these procedures weren't done preventatively or proactively, maybe causing long-term issues. So healthcare is changing. I think, like I said, and I think everybody's talking about today, the telehealth version, getting those things done proactively before maybe the procedures needed is the goal. So.
Absolutely. Thank you. Okay, so the next question is for Erica. What considerations do you see suggesting to employers regarding plan design or their contributions for 2021?
Yes, so the majority of the employers that I've been speaking with, their biggest concern right now is they generally care for their staff and their employees and their families. And what's been communicated thus far to me is if this can be the year that I make no plan changes, I just want to keep everything the same for my employees. I understand once renewals start hitting, and there are going to be increases, I'm quite certain of. Health savings accounts, never a bad option to look at. I always recommend health savings accounts, health reimbursement arrangements are just a couple of great ways to get creative and have alternative funding options for your employees. Not necessarily get rid of the plan that you currently offer. What we see from most surveys that we have with our groups is that employees want options. So the one plan, the one size fits all approach is not for everyone. So my recommendation would be give your employees options, let them choose what's best for their family, because the needs are certainly different across the board. So that would be my recommendation.
Great, thank you. Okay, so the next question is for Jeff. Will increase in demand for delayed procedures and continuing care related to COVID-19 likely drive healthcare costs higher for 2021?
Yeah, I think I alluded to that in the last question as well. There's really just no way around it. Yes, this will have a financial impact on our industry and your industry as a whole. Those delayed procedures, it's kind of an unknown, right? What is not getting treated right now and what will come as a result of that? Hopefully people are being proactive in using the telehealth services because of low cost share or no cost share, right? And they're still getting treated or getting seen. My fear is that there's members not taking medications because they don't want to go get it and they didn't take that proactive step to get the at-home mail service. You see that a lot in the diabetic space, where people will wait until there's an issue, and those drive costs considerably. So I'm hoping that people are still taking good care of themselves, but being cautious as well about getting out and about. But yes, whether it's in a form of premiums or whether it's in a form of taxes, this will come from somewhere. That dollar has to come from somewhere. And as those out-of-pockets are being covered by somebody other than the member, those dollars, again, have to be absorbed somewhere. And at the end of the day, the consumer is always the one who ends up eating that cost in some form or fashion. So yes, I would anticipate over the years that would drive costs. But in the short run, as Erica mentioned as well, claims are down overall, but I'd hate to be an underwriter right now. You've got very little data to go by because the reality is it's not a normal year, and they're having to project not only this into this year, 3 or 4 months of data that they don't see yet, plus another 12 months at a minimum of next year. And there's a lot of claims that are sitting out there just waiting for January 1 or whenever the hospital is allowing that procedure. So underwriters are not in a great position right now, so I don't envy them.
I have a question. What about the patients that are being hospitalized with COVID? How is that impacting? Are they seeing large claims for those people that are being hospitalized as well? And will that impact the renewal?
Sure. Yeah, I mean, that's a great question. As Erica alluded to earlier as well, I don't think yet Southwest Missouri, from a claims perspective, has seen that be an issue yet. Again, our hospitals are well equipped. We've got 2 great health systems in town. Cox is well equipped right now, and they're doing that proactively, right? The goal is to not have those beds filled. But yeah, a ventilator is not cheap to have running, right?
Yeah.
And it's not cheap for the member, it's not cheap for the hospital system, and it's not cheap for the health plan that's covering that member. The government intervention right now is helping kind of share that burden. So the member is not seeing that, but the plan will pay a part of that, and the government, of course, is supplementing that. So I think we will have some of that burden, but I don't think, at least now, the biggest factor. I think the economic factor is much bigger for our area right now.
And I'll build on that just a little bit. We had an update yesterday from our CEO who was talking about, we've been very fortunate in Southwest Missouri to have sort of a delayed impact of COVID here. So it came into our area later than some of the Seattles and New Yorks. And so because of that, science has actually progressed. We're seeing more and more where patients who become hospitalized are actually being released in 4 or 5 days versus just spending 30 days, 60 days on ventilators. And so I think that was hopefully helping that sort of scenario as well for us locally.
Thank you, guys. Okay, so the next question is for Erica. Is this a good time to review or expand on voluntary benefits? If so, why?
Yes. So I am a huge advocate for voluntary benefits. It's really a win-win because the employer can offer voluntary benefits and not contribute towards the premium. So it gives the employees options, and it just rounds out your benefits package so that you can offer benefits that will attract and retain quality employees. So there's never a bad time to offer those benefits. Of course, with the majority of employers at that January 1 renewal, if you are January 1, now's a good time to start evaluating that because especially if you have an employee survey, the feedback we receive is those are very valuable benefits to your staff. Even if they're paying the premium, obviously, since they're voluntary, it's just the fact that the employer is offering them those benefits. So it's always a great time to offer them.
Great, good advice, thank you. Okay, so the next question is for Bridget. So what virtual telehealth visits for specialty care are currently being provided, and how are the restrictions different than primary care virtual visits?
So essentially, every specialty that we have at Cox Health is equipped to do telehealth. It might be utilized in different ways and in different facets, but the restrictions are not necessarily different specialty to specialty or primary care to specialty. It's really going to be more specific to the patient and the types of chronic illnesses or disorders that they're treating. Some lend themselves to better be evaluated through telehealth, and some don't. I think a lot of people think surgical would not be a use case for telehealth, but actually you'll find that oftentimes, let's say, for example, a spine surgery, that initial consult with your spine surgeon, they're really just reviewing x-rays with you that you've already had and just kind of evaluating. They're not necessarily touching you, but they're just kind of reviewing those x-rays, giving you some options, talking about your game plan. That can be done via telehealth. Now, obviously, you're going to have surgery, and then you're going to have your post-ops, and they definitely do want to see and touch you in those arenas. But you'll be surprised that telehealth can insert itself in many different ways. I think the most restrictive is probably pediatric care. I do think that there is just a higher need to get a hands-on when you're talking about children because things can really make quick turns. And you certainly don't want to misdiagnose things. Strep throat can lead to kidney disease and kidney failures, and so you just don't really want to miss things with the children, and you really can't overprescribe to a child. So pediatric probably has the most limitations, in my opinion, but we can still do some pediatric care, of course. So it's really going to be case by case.
Awesome, good information, thank you. Okay, the next question is for Jeff. So for employers that are currently using EAP programs or considering providing an EAP program, how would you suggest better education of that service to the employees?
Sure. Many of you probably already have EAP built into your voluntary benefits package or your employer-sponsored packages anyway. And I get this question a lot: how do I communicate that to them without forcing it on them or without being a part of that? Because there's a member confidentiality that adds value to it. Similar to communicating any of the COVID information, it kind of depends on your workforce. If you have electronic capabilities, that's ideal. If you have an enrollment platform that's online, COVID is probably opening your eyes to that possibility now. versus the old face-to-face employee meetings that we used to do and still do. Maybe still incorporating a virtual employee meeting as well, but an online enrollment platform typically has the ability to upload additional information, but messaging or summaries of those services, again, company intranet, those sort of things. If you're still old school, as Erica mentioned, and sending out paper checks versus direct deposit, I've seen employers do statement stuffers, for lack of better words, put a single flyer in with their paycheck. That's an envelope they open every time. They don't leave that one sitting on the desk or on the trash can. So that's a good option if you're still doing that. But then also quarterly or monthly emails, whichever you think fits your audience best, just from HR or from leadership team saying, hey, pick a topic, every month or every quarter and say, hey, just want to let you know we have this available. If you have questions, reach out. But I think, quite honestly, the biggest value that an HR professional can do for EAP is to remind people that it is confidential. You don't get claims reporting on that. That's the biggest barrier I think people have when seeking not only mental health, but any of these services, is because it's tied to an employer-sponsored plan, they automatically assume if I call about a substance abuse issue going on in my home or divorce, that I'm thinking is inevitable, and now my employer or my HR, manager knows what's going on in my home. And that's just not the case. And quite honestly, there's a lot of protections in place for that. And one of the reasons why we also get some pushback about the reporting aspect of it is, well, how do I not know what utilization looks like? That's part of it. Is they want to limit that because they don't want you having that information. So it's, again, a little bit of a leap of faith when you offer an EAP program that maybe costs a little bit extra, that if you provide it and you give access to your members and remind them of the confidentiality of that, then you're possibly preventing a lot of bigger issues for your workforce.
Awesome, thank you. Okay, the next question is for Erica. So what processes do you suggest employers should review or implement for the upcoming enrollment period?
Yes, so I don't think it's going to come as a surprise that our 2021 open enrollment, especially, I hate to keep going back to January because I understand every employer is not January, but that is going to be our first open enrollment in 2021. And so right now is the time to be preparing for that. And at our organization, we are already preparing now because the majority of employers, a lot of them are working remotely. They don't have all the staff back in the office yet. And so we're preparing for virtual meetings. And that's not to say that every client is going to have a virtual meeting. Absolutely not. We understand that the needs of every organization is different. And so we may have some groups that still want to have the in-person group meetings. We'll be happy to hold those. Social distancing, of course. We also have some that like individualized meetings so that they have that one-on-one. That's something we'll certainly still provide. As Jeff mentioned, there's online enrollment systems, benefit admin systems. That's a great way to somebody that just wants to do it themselves, go online, walk them through their benefits. That is a great option. There are many ways. Of course, I mentioned the virtual meetings where, we can do an in-person meeting and record that and then distribute it to the staff so that they can watch it at their convenience. We've done recorded meetings at our office where then it's distributed to the employer for them to distribute to their staff. So there are going to be many ways in which you can get the benefits communicated to your employees, but I would say that's probably the biggest, I hate to even use the word obstacle because it's what we're all getting used to is the virtual meetings and online, but I'd be preparing for, virtual or electronic enrollment if you don't have, the benefit admin system or online enrollment. Now is a good time to look at that option. So especially if you don't have individuals on site to be distributing, open enrollment materials, if online is a good way to go.
Absolutely, thank you. Okay, so the last question here is for Bridget. So telemedicine utilization has increased considerably. With the increased utilization, how has this impacted patient privacy and quality of care?
And we obviously will take patient privacy very, very seriously, whether it's done virtually or in person. There are a variety of telehealth platforms, and so we make sure that our telehealth platforms are screened and going through all the appropriate security checks, and we're meeting compliance. In some ways, I think it can be more secure when you think about, you know, going into a clinic, you walk up to the front desk and you're kind of in a room full of people, potentially people can hear you speaking. So this is very one-on-one and very closed in. We have private office spaces for our providers to practice from. So it is very secure, and I think it's, you know, the key in that is making sure that your platform of choice is also secure with you. And so we work very, very hard on that. So
I would like to also just go back a little bit to talk about the voluntary benefits and EAP and telehealth and all of those voluntary programs that employers have a choice to choose. How is that in the overall going to help them decrease their overall costs? That might save them money, which is going to be a big concern when the renewals come out and going forward. So that's for all three of you.
The easiest one is the tax burden. So if you have employees electing voluntary benefits and it's coming out pre-tax, now your tax liability as an employer is reduced by those dollars no longer being considered income. So you're not having to match those dollars. You can choose to if you want to from a benefits perspective, but also in the preventative side of voluntary benefits like dental and vision, things being found much quicker, like diabetes, do a vision exam. Those sort of things have real numbers and data to prove that they actually save a plan quite a bit of money down the road. So those are just two real quick ones. But
I was going to say, you know, I think telehealth allows for that earlier intervention and prevents things from kind of escalating further. Sometimes patients can't drive to get to the care they need, or they just don't want to see the stigma of being in those locations. And so I think getting that earlier intervention and in often cases, not all cases, but telehealth can be offered at a lower price point as well. And so the combination of that, I think, will significantly impact that. If you think about COVID specifically, you know, getting treatment and seeking tests earlier from home, from a safe place, will reduce the spread. So it all kind of funnels together, I think.
And I completely agree with what Jeff and Bridget have said. The only thing I would add, since I think it was the only one that wasn't mentioned, EAP, an employee assistance program. If your staff members are seeking help and counseling and being able to, you know, just use suicide as an example. If there's a hotline that they can reach out to that prevents them from harming themselves or from committing suicide, I mean, that's certainly going to not only benefit that member, but keep your plan utilization down, because then that claim is not going to be hitting your plan. So suicide is just an example, but there's many resources available within an EAP program to assist that member through whatever they might be going through in life. So.
Absolutely. We do have a question in the chat, so I'll go ahead and read that one. Is there any action an employer can take now to identify those who may have suspended maintenance care they were previously obtaining? And so what can we do to address this and avoid negative impacts for 2021?
Well, that one's kind of, I mean, I would say that's kind of a tough one because of HIPAA and I mean, they have a lot of protection. I mean, my only recommendation just right off the top of my head would be some sort of memo to staff, like, hey, as a friendly reminder, you know, if you put any care on hold, don't delay, you know, some sort of proactive approach to communicate to them, again, whether it's an email or whether it's a flyer. Maybe it's just a great time to remind them of the benefits available that you offer, you know, or if, you know, maybe now's a good time to communicate mail order. I know Jeff mentioned, you know, some individuals, they may not be taking their meds because it's like, well, I'm not getting out and going to the pharmacy, and maybe they don't live in an area where their prescription can be delivered, you know, so maybe just re-educating on the mail order options for their prescription drugs.
I have a quick question. What about the employer groups that have been fortunate enough, and the employees particularly, in having health fairs and having testing done at the health fairs and the wellness things? Do you have any suggestions going forward for companies
typically something that is provided at the time employer groups do their health benefit fairs. I've had employers already reach out to me to let me know they're not going to do their health risk assessments this year as they typically do, just because they don't want that gathering of everyone coming and going. And so a good replacement for that would be to just make sure they're seeking that wellness check with their preventative care, that they're at least getting that annual visit, and then they can just provide a note to the employer, you know, the physician note saying, hey, they, you know, preventative check done. So we certainly don't want this to be a year in which the employer doesn't offer the health risk assessment and then they're not having that annual blood draw or that annual check. So definitely don't completely do away with it. Just maybe get creative in how you replace it so that they're still seeking that service.
And we are continuing to do health risk assessments, I think in a much more structured way. And so we do have policies and procedures on how that looks now, with masking, with more scheduled occurrences, so people aren't all kind of coming in clusters. So we are doing those. They are coming out, but we're just reevaluating how they occur.
And I'll just add to that too, most of the wellness programs have some sort of online platform that requires some sort of self-reporting that you went and got your checkup, or that you're walking or doing whatever those goals were established for you. So I'll just encourage you to continue to do that, and maybe more so push that avenue more than you have in the past. Because of this, it adds value to the fact that you have that access. So yeah, just keeping people active. I know in my neighborhood alone, I saw a lot more people out walking during this than I have ever before. So maybe this is a good reminder that we can do this, take a little bit of time, slow down, and take advantage of it.
I have one more question, and that is to all of you. And this year coming up, the renewal, are we going to be seeing a lot different time frames in which people can expect their renewals, the preliminaries? Is that something that's going to be available, do you think, or there's going to be shorter time frames, and most groups are going to be required to wait and provide the full data now in order to get their renewal? So
I haven't heard of any carrier notifying us yet of delayed renewals. It really depends on the carrier and depends on the size of the group, the size of the employer. You know, if you're in that 2 to 50 employee range, 60 days is really that mark on renewal. 51 to 99, again, depending on the carrier. Some carriers are strict on the 60-day, and then some, 75 days out from renewal. Large group, which gets into 100 plus employees, those are typically released 90 days out by the carriers. And then certainly there are some groups that, you know, have 250, 500 plus lives, and those are really, depending on the size of the employer, negotiated with the carrier. And Jeff may have seen something different, but I haven't heard from any carrier where this has caused a delay in our renewals being issued.
No, I think, quite honestly, saying 60 to 90 days is pretty typical on most renewals. Now, from an employer's perspective, that timeline may change for you because you're wanting budget talks to happen earlier because of the economic impact that's already happened to you. But you have to remind yourself that underwriters are using a partial year worth of data, having to predict not only the fact that they've got a set amount that they can collect from for the rest of the year, and now with COVID, the 60 to 90 day time frame I don't think is going to get adjusted. I don't think they're going to be delaying those either. But one thing that we have seen, and I'm sure Eric has as well, on the voluntary benefits side, a lot of the carriers have gone out and said, hey, we're not going to provide any rate increases this year. Systematically, administratively rather, it makes it a lot easier for them, especially when they're probably in a work from home environment as well. They don't have to have underwriters touching every single renewal. So if you have a dental plan or vision plan or short-term long-term disability plan, most likely the majority of those lines are getting a rate hold this year, depending on the carrier you're with, unless you've had some large claims that justify otherwise, which is a significant efficiency for you as an administrator to maybe just do a passive enrollment on those lines this year, especially if you're used to a face-to-face enrollment option.
Now with the medical carriers, we just do the same, right?
Yeah, right?
Flat renewal.
I had my fingers crossed as those emails were coming out, and I was like, come on.
I wish we could get to be true. I'm just putting you on the spot.
All right. Well, if there's not any other questions, we didn't really have that many questions in the chat. So if you guys don't have any other questions, we'll go ahead and wrap up. I just want to say thank you to everyone for being here. We did record this meeting, so we'll get that out to anyone who maybe having to jump off early or couldn't attend this morning. And then, like we said before, we'll go ahead and attach the speaker bios to the email as well, since we kind of had a technical difficulty in the beginning. So we apologize for that. And again, thank you to the Comp and Benefits Committee and to our leader, Carol, and everyone have a great day.
Thanks for having us.
Yeah, thank you.
Thank you. Thank you. Thanks for our presenters as well. Goodbye, guys.